This research is presented on behalf of the FAST MRI study group. We benefited from research capability funding from the NIHR and obtained approval both from the Health Research Authority and from the Research Ethics Committee for this study. These mammograms are of a woman who presented to our symptomatic clinic in 2015. She'd found a lump in her right breast. Her mammograms are normal, but her subsequent breast MRI clearly shows her grade 3 invasive ductal cancer. These MRI images are those that would have been obtained had she had a type of abbreviated MRI called FAST MRI. And these contrasting images illustrate the background to this study. FAST MRI has been suggested as a screening modality for a wider group of women than those currently offered screening with breast MRI. Its short acquisition and reading times promise potential cost effectiveness, but any change in screening modality has workforce implications. We need to know whether the existing workforce of NHS BSP mammogram readers can quickly learn to interpret FAST MRI with only brief additional training. So the premise at the heart of this study is that if professionals, including non-radiologists, who are already competent at reading mammograms, can be effectively trained to interpret FAST MRI within a one-day course, then training the NHS BSP workforce to interpret FAST MRI could be considered feasible. First, we created a data set of FAST MRI examinations from breast MRIs performed during 2015. We decided to enrich the existing screening data set with additional cancers and to exclude large invasive cancers because we wished to create a challenging task for our image readers. So therefore, our enriched data set comes from two separate populations of women, namely those who had their MRI as part of their high-risk screening and those who were imaged following a new cancer diagnosis. So the enriched data set is not a real-life series in the same way as a Perform's mammogram set is not a real-life series because it's been created to be challenging. This slide shows the clinical indications for the original MRIs. 72 were performed as part of high-risk screening, and this included 2 that had a unilateral cancer. The remainder of the table shows the spread of indications for MRI in the post-new diagnosis cases. In total, we had 54 invasive cancers, including 52 that were unilateral and 2 that were bilateral in the same patient. And we also had 2 cases of unilateral high-grade DCIS. And this makes a total of 56 breasts with cancer in our data set. It's interesting that 18 of the 56 cancers were occult on mammogram, and also we had a high proportion of lobular cancers, much higher than the expected 15% in any natural series. So this is a complex table which details the cancer histology here. And in the bottom half of the table, I've tried to split the cancers to their category or their likely category as luminal A, luminal B, and triple negative. So next, we recruited 8 image readers. So 4 image readers were image readers who read breast MRI and mammograms for NHS BSP, designated Group 1, and 4 image readers were NHS BSP mammogram readers who do not read breast MRI, designated Group 2. And while Group 1 were all consultant radiologists, Group 2 comprised 1 consultant radiologist, 1 consultant radiographer, and 2 film reading radiographers. Each image reader received half a day's structured training, including a one-to-one workstation session with instruction and formative assessment, followed by a small group interactive presentation on difficult aspects of fast MRI interpretation. Then all 8 readers read the enriched data set of 250 breasts displayed as anonymized fast MRI examinations. Each image reader was blinded to the opinions of all the other image readers, and all 8 image readers completed the data set of 250 breasts, which gave in total 2,000 interpretations for analysis. This results slide shows that Group 1 image readers on average took less than 1 minute to interpret each fast MRI, and Group 2 image readers took on average less than 1.5 minutes. In the bottom table, we can see that 22% of our original data set, and therefore 22% of our 2,000 interpretations, had a true result of cancer. We asked our image readers to classify each breast according to the UK 5-point classification that we're all familiar with, where 1 and 2 are normal and benign, 3 is uncertain, and 4 and 5 are suspicious and definitely cancer, respectively. And this lower table shows us that for the breasts with cancer, with a true cancer, 88% of readers' interpretations classified that breast as MRI 4 or 5. And this contrasts with the next column here, where we see that if an image reader classified a breast as MRI 3, then that breast was actually 9 times more likely to be a normal breast in real life than to have a real cancer. So the overall concordance of the image reader's interpretations with the true results was better when MRI 4 and 5 interpretations were considered to be cancer than if MRI 3 interpretations were also considered to be cancer. But we would need a prospective trial in a real-life screening setting to determine whether recalling just MRI 4 and 5 classifications could be an effective screening strategy when using fast MRI. This table again shows the concordance between the image reader's results and the true outcome, but it's individualized for individual readers, the Group 1 image readers at the top and the 4 Group 2 image readers at the bottom. And we can see that 90%, for the Group 1 readers together, they achieved 90% overall concordance, and that the Group 2 readers achieved just 5% less, 85%. And this level of performance was achieved by a group of professionals with no previous experience of reading breast MRI after just half a day's structured training for all except reader 2.2, who actually requested and had delivered a second half day of structured training, which was delivered 2/3 of the way through the reading task. So, in conclusion, following less than 1 day's training, Group 1 image readers did very well at fast MRI interpretation, achieving 90% overall concordance, and our Group 2 readers, despite having no previous experience of interpretation of breast MRI, did just 5% less well in terms of overall concordance, almost as well as Group 1. And therefore, this study suggests that training the existing workforce of NHS BSP mammogram readers to interpret fast MRI is likely to be feasible should fast MRI be shown in the future to be cost-effective for screening within the National Health Service breast screening programme. Thank you.